Today I'm going to be looking at basic ventilation at district hospital level, which is something that can be a bit intimidating if you don't do it regularly. Now, I've covered lots of the building blocks before you get to the ventilator already. So if you're interested, there are videos on the anaesthetic machine check, on taking you through the process from induction of anesthesia to initiation of ventilation, and then also all the airway management things. So the holding a mask and supraglottic airway devices, intubations, crash inductions, and those aspects have already been covered in some detail. So I'm starting this talk at the point where you switch on the ventilator from having inserted the tube. Which means I'm assuming that you have prepared well, which means the anaesthetic machine's checked, the airway trolley's checked, the theatre is ready to go, your anaesthetic machine has power, etc. I'm assuming that you've already intubated the patient, and that means that you have checked that the tube is in the correct place. Just to remind you that you saw it go through the cords, you've listened to all the areas in the chest, there is end tidal CO2, the chest is rising, the tube is misting, you've strapped it appropriately, and importantly, you've noted the depth of the tube when you put it through the cords at the teeth so that you can adjust the tube if it gets moved. And that's all been done, and I'm not going to get into that today. Some tips. Set the ventilator before you even begin anesthesia. It's a thing that you do before you even start pre-oxygenating the patient. And ask yourself honestly, who does this? But why wait until that moment when you've just strapped the endotracheal tube, you're bagging the patient, and now you're trying to remember what 8 mils per kilogram is for a 67 kilogram patient. Do it before, and then the settings are there on your machine, and when you press go on the ventilatory mode you've chosen, it will just kick in. If you forget to set these settings and you just press volume control ventilation in a pediatric patient, you're going to get an adult volume delivered to a pediatric patient. So if you have forgotten to set the settings, rather choose pressure control ventilation, because a pressure of 15 can be used in an adult or a child, whereas a volume of 500 is not so good if it's a 10 kilogram child. So if you have forgotten, move to pressure control ventilation. It's safer as a kind of the initial settings. And then use a test lung to either learn how to use the ventilatory modes that I'm going to be chatting about today, or even if you want to have a look how that works before you start your anesthetic, you can put a test lung on the circuit and just run the ventilator on that test lung. Now, a test lung, if you've got money, looks a bit like this. This is the Draeger one, and they look very fancy, but you don't need a fancy test lung if you don't have one. You can use just another bag. So like you use for mask ventilation, when you squeeze the bag, you just put one on the end of the circle system, and you can see there someone's even taken a glove and put it on the end, and you can test the ventilator with a non-sterile glove on the end of the circuit. And basically, if you stick that thing on the end of the circle system, you dial up your gas flows, you can put the ventilator on into a mandatory mode, and it will just ventilate that bag as if it's a patient. And it's a good way to learn how to set a ventilator and how to move between it and adjust it while the patient's being ventilated. And really, you can do this when there's no patient in theatre. So there's no excuse not to have learned how to run the ventilator. Whenever you set a ventilator, there are 4 types of trauma you must consider every single time you set the ventilator. The first is barotrauma. That's the one everyone remembers. It's pressure trauma. So if you have too much pressure, you damage lungs. That makes sense. So we need to think, how is our ventilation causing pressure, and what is the difference in pressure between the highest pressure and the lowest, which is called your delta P. There is a thing called volutrauma as well. So if you give too much volume to lungs, even if you don't get high pressures, and you can picture that with a balloon that's been overinflated, it can keep inflating without the pressure going up. So stretching lungs too much causes damage to lungs, and that's why we limit volumes that we ventilate at somewhere between 6 to 8 mils per kilogram. Atelect trauma is definitely one people will forget, and that is basically when you collapse and inflate alveoli, and the way that you prevent that is by putting enough PEEP in, positive end expiratory pressure, that holds those alveoli open, so there's no collapse and opening, collapse and opening. The shear forces of opening those collapsed alveoli sequentially causes lung injury, which we obviously want to avoid. And finally, there's biotrauma. And really, in our setting, that relates to oxygen. And that's just a reminder that oxygen is toxic. As soon as you go over 21%, which is pretty much what room air has, that starts to damage lung tissue. And so while we start anesthesia at 100% oxygen, you want to come down to whatever the lowest safe level is for anesthesia. And that is somewhere between 30 and 40% oxygen, depending on your patient and how experienced you are. But I never really go below 30% oxygen, and I would recommend 40% as a lower limit if you're a beginner. So those things relate to pressure, volume, PEEP, and oxygen. And those 4 variables you must always think about whenever you're setting up the ventilator. So there are a lot of modes of ventilation, and I'm just going to run you through the most basic 2. And these 2 really form the foundation for all the other modes. The first is volume control. And you can see there that when you're on volume control, there will be a little light depending on your machine. This is a Drager, tells you that you're on volume control. And here you set the volume, and the pressure will change with each breath. So I decide to give my adult patient something like 400 or 450 mils, and each breath will give exactly the volume that I have asked it to give. But the pressure that it generates may change as lung compliance change, or someone puts their hand on the chest, or there's a pneumothorax. The pressure will change, but the volume that you deliver will be fixed. The opposite is pressure control, where the pressure is fixed. So I say give 15 centimeters of water, and the volume will change as the chest compliance or the resistance of the airway changes. So in each of those, you set one variable and you watch the other. Volume, you set the volume and you watch the pressure. With pressure control, you set the pressure and you have to watch the volume. And the easier one conceptually is probably volume control. People find that easier. I set the breath rate, I set how much tidal volume I want, and that's it. And it does make more sense. The one that patients tolerate a little bit better, and the one which is probably slightly physiologically better, is pressure control. But I'm very happy that you start with whatever everyone in your institution is used to and get to know one mode, get to know it well, and then start playing with the other mode once you're comfortable in one of the modes. The other concept which is worth thinking about is whether the breaths you're delivering are synchronized or mandatory. With synchronized breathing, the ventilator will time a breath with a patient effort. So it will detect that the patient is trying to take a breath, and it will synchronize either the pressure or the volume it wants to deliver to that breath from the patient. And it will pick it up whether the patient starts taking a breath by detecting negative pressure, or that the flow from the patient is going the other way because the patient's drawing in, so a negative flow. And it will, detecting that, that's called the trigger, detecting that will then result in the ventilator supporting that breath. That's called synchronized ventilation. Mandatory ventilation, it's on a fixed time interval. It'll just deliver the breath irrespective of what the patient's doing. And so for that mode to be working nicely, the patient should either be paralyzed or not breathing. And in general, it's worth learning about synchronized modes, because the synchronized modes can often give you both. You can get a mandatory breath if the patient isn't breathing, but if the patient does try and breathe, it will time it and support that breath. So you want to learn about synchronized modes whenever you can. I'm going to come back to this concept just now. So if you're setting a volume control ventilation, you might set the volume at somewhere like 6 to 8 mils per kilogram. So for a 70 kilogram person, that would be 420 to 560 mils, something like 500 mils. You would monitor the pressure. You'd set the respiratory rate at something like 12 to 16, whatever you want in that range. And you would start the oxygen at 100% and come down to 40 once you're happy that you're ventilating well. PEEP, anything between 5 and 8. Everyone should get PEEP. I personally, my standard is to start at 8. The only patients that don't get PEEP are the exceptions. So if a patient's an asthmatic and currently wheezing, and you're having an asthmatic attack in the patient, then you put the PEEP at 0. And there's very rare circumstances where you don't use PEEP, but the default is PEEP. And then the flow, the gas flow rates, start at 6 liters per minute for 6 minutes. So you can wash in the volatile anesthetic and go down to 2 liters per minute once you're stable. That's the guidelines for district hospitals. You'll see in tertiary hospitals we go a lot lower than 2 liters per minute to save money. But for beginners, before you've got your diploma, 2 liters per minute is the minimum flow. For pressure control, you'd monitor the volume while setting the pressure. And I usually start at about 15 centimeters if the PEEP's 5, so a delta P of 10, similar rate, similar oxygen, similar flows. And then I will adjust the pressure that I've set to the volume that I want. So I know I'm trying to get 500 mils. I'll just play with that pressure till I get the volume I want. And these modes are almost exactly the same. The main difference is the way they generate the support. So the flow rates that they use, the volume control is a very high flow rate initially, which then comes down, whereas the pressure control is more of a square flow rate. That has differences for the way it delivers the air, and as a result, for the same pressure, you get a little bit more volume in pressure control than you do in volume control. But those are the minutiae, and you don't have to worry about that too much. It's a sort of thing that you'll play with as you get more experienced. So in all of these patients, you give them the oxygen that they need, you set the respiratory rate, you set the PEEP, you do the flow rates the same, and then all you're really changing is whether you set the volume or you set the pressure. Now remember, ventilation is a dynamic process. You can't just set the ventilator and then you're done for the operation. So you have to monitor certain things, and you've got to get used to watching the ventilator and the response to the ventilator. The first thing you want to watch is pressure, especially if you've set a volume. So watch the pressure, see what your peak inspiratory pressures are, see what your plateau pressures are, and have a feeling for what the patient had at the beginning and watch how it changes. The second thing you want to watch is the volume. So are you delivering the volume you set, or what are you getting for the pressure that you set? Both of these things are worth watching, and they can change intraoperatively. You can think about a cesarean section. Often the lungs are a little bit compressed because there's a 3-kilogram baby in the abdomen. They deliver the baby, and suddenly, if you've set volume, the pressures will come down. Or if you've set a pressure that's fixed, the volumes will go up. So you may have to adjust that ventilation once the baby's out. And so you must always be watching the pressure and the volume at all times. I'm always glancing up at the ventilator, checking. And then watch, are you oxygenating well enough? And watch what's happening to the carbon dioxide, the end tidal carbon dioxide. That is a very good monitor of what your minute ventilation is. So CO2s that are either drifting down or drifting up are often telling you something. So continually evaluate the efficacy of the ventilatory parameters you've set. So this is volume control ventilation. This is taken off a Drager Fabius, which is a common machine in the district hospitals. And you'll see there that the volume control light is on, so that tells you what mode you're in. This ventilator's got volume and pressure control, and then pressure support, and then an SIMV mode. Now, that we've set volume, so we've set the frequency, we've set the tidal volume, and the minute ventilation. And then once we've set those things, I think that tidal volume it delivered wasn't exactly what was set. You must also look at what pressures you're generating. So the plateau is 17 and the peak is 20. And this person's hardly set any PEEP. That's at 2, and that's too low. But those are the sorts of things you'll watch, and the oxygen up in the corner is 94. If you look at pressure control ventilation, here the light for pressure control's on. There they've set a peak pressure of 25. So every single time the ventilator is going to give 25 pressure. And notice now it's delivering 661 mils. So that 661 is what that pressure generated. The minute ventilation is 7.8. The frequency was set by the user because this is mandatory ventilation. So those are the two modes, pressure and volume, and those are the things you've got to watch. Now, each machine is different, and this is what you should practice with the test lung. But I just want to show you how you can change between the two modes, and you can change the settings between the two modes in real time. So here, this is now the patient's being ventilated on volume control, and this person wants to change to pressure. So they press it once, they can check and change, and they confirm with the wheel, and now they're on pressure control ventilation. So you can see now the ventilator actually gave suggestions for what those numbers should be. Here we're now ventilating at 25, you're getting 660 mils. If you press volume control, you see it's suggesting that 660 should be the tidal volume, and then confirms, and then that's what's delivered. So these ventilators are very intuitive. They actually work out what the numbers will be if you change modes. So they'll often give you suggestions when you're changing across like that. And those things you can practice, like I said, with a test lung. So now this, coming back to synchronized versus mandatory ventilation, this shows an SIMV ventilator. SIMV stands for synchronized intermittent mandatory ventilation. And you can see here that they've set their oxygen as at 36%, the tidal volume is set at 520, and they've got an inspiratory time, which I'm not going to go through today. Frequency is set at 12 and the peeps at 5. So those are all sorts of things you would be expecting to set. They've also set the delta P of pressure support. So in this case, they haven't set anything. But if you dialed in 5 or 10, the extra breaths that the patient takes would get that pressure. So that is a volume controlled ventilation, but if there are any extra breaths, they will get given some pressure to support them. And this is a common mode. And you can actually see on this trace where that arrow is that there was an extra breath that the patient took. And you can see that the volume was much lower than the other breaths because no pressure was given to that breath. And so if I was ventilating this patient, I would dial that delta P up to 5 or 10 and see that those extra breaths also got some support. And you should try and set synchronized modes of ventilation. So I dial in an SIMV mode, whether it's a volume or a pressure SIMV, and I set a mandatory rate of something like 12, like this person's done. And then any extra breaths will get supported by the synchronized breaths. And often if you're doing anesthesia where paralysis is needed, you can use this mode. And then once they're breathing nicely, you can turn off the mandatory breaths and just let them have supported respiration. It's a nice way to do anesthesia. Just to remind you, this, I'm not going to get into this in any depth, but here there is spontaneous breathing, which are those dotted lines, and you're seeing the pressure go negative as the patient takes a breath in, and then positive as they breathe out. And then you get a mandatory breath, which is a solid line, and there was no trigger. So that was the ventilator just delivering a breath. Nothing made the ventilator synchronize it. The next time it happens, you see the spontaneous breathing. Now there's this little negative breath that the patient took. It went down, and then the ventilator assisted that breath. So that's an assisted mandatory breath. And that's because the ventilator is trying to deliver its 12 breaths, and if there was a breath around about the right time, it's supporting that breath. So that's synchronized ventilation, and it's something worth looking into. Now, there are two traces you must always look at while you're watching your ventilation. I discussed earlier that you must watch what's happening with pressures and volumes and oxygens and CO2s. One of the pressure traces you must look at is this one, and you'll see that there's a peak inspiratory pressure, which is the peak of this trace, and then a plateau pressure. And both of those numbers are worth watching because when you're dealing with problems, you can use the patterns of the changes to diagnose the category of the cause. So the peak inspiratory pressure goes up when resistance goes up, and the P plateau often talks about compliance. And just to show you how you would do that without getting it into too much detail, if the pressure goes up in the ventilator, you can look and say, look, the overall pressure is up, so that's the peak inspiratory pressure. Is the plateau pressure also up, or is that normal and I've just got a high peak inspiratory? So for the first category, the peak inspiratory pressure is up, but the plateau pressure is not up. That means there's airway resistance. And the differential diagnosis is airway secretions, bronchospasm, kinks in the tube, the patient biting, something stopping the air getting into the patient. That's what that pattern gives you. And that'll help you decide what's the cause of raised pressure. If both are up, so the plateau pressure is also up, that's a compliance problem with the lungs, so abdominal distension, pleural effusions, pneumothorax, ALDS, pulmonary edema, pneumonia, that's the sort of thing that does those problems. So it's a useful trace to look at, and I'm not expecting you to remember this now, but get used to looking at pressure traces. If you have a ventilator problem, many people use this mnemonic. It's called DOPES. D is for dislodged tube, O for obstructed tube, P for pneumothorax, E for equipment failure, and S for stacked breathing. You can use these things if they help you, but you need a sort of systematic approach. And what I would suggest is that when there is a problem with ventilation and you're not delivering what you want, turn the oxygen up, turn the flow rates back up. If you were at 2 liters, go back up to 6. That should be a reflex. And then what I normally do is I switch over to manual ventilation. So I'll switch the mode from those pressure or volume controls to manual. I'll dial the APL valve down and I'll use the bag to ventilate the patient with my hand. And I get a lot of information from how much pressure there is when you bag ventilate. And if that's not working still, I may even disconnect the ventilator and use an ambibag. And if I'm still not able to squeeze air into the lungs with an ambibag, that tells me the problem is between the tube and the patient. So a big mucus plug or a kinked tube, or the patient's bitten down. If I'm able to bag easily, it tells me the problem is before the patient, so in the circuit or the ventilator somewhere. Get used to looking at capnography traces. This is what a normal one looks like. Look at these things. If you see enough normal ones, when you get a different one, you'll say, oh wait, that doesn't look normal, and you can start thinking. So for example, this is called a shark's fin capnography, and this suggests bronchospasm. And so when you see the difference, you can say, hey, that's not looking right. Then you examine your patient and you'll pick up bronchospasm. This is rebreathing. Another common one, you'll see the baseline CO2 doesn't return to baseline. It's climbing on each breath. And the most common cause of this is rebreathing. So your soda lime is out the circuit, or the flow rates aren't high enough, and the patient's breathing spontaneously. These are the sorts of things. Just remember, the other reason that this happens is malignant hypothermia when the temperature is really high, but the usual cause is rebreathing, and fairly easy to troubleshoot. And then this is called a curare cleft. And so when muscle relaxation wears off and patients start to breathe at the end of a delivered breath, you get that pattern. And there are lots of different patterns. That's just some that I've chosen. The message that I want to send to you is that you look at capnography traces and you use them to make diagnoses. And this is what you should do continually. And you should practice. Now, this is a slightly more advanced anesthetic machine. And here we're doing SIMV mode plus pressure support. And so there's the pressure support. So this patient's dialed in 600 mils tidal volume at a rate of 12. They've set the maximum pressure at 40. And then they've said if there are any extra breaths, you can give 9 pressure support. And those lines there that are on the pressure tracing, that indicates the patient trying to take a breath. And so you can see as the patient takes a breath on that one that the arrow is pointed to, the ventilator then assists that breath with that pressure. So that's called pressure support. That is SIMV plus pressure support. And it's a good time to practice pressure support ventilation when you're waking patients up. So you're trying to get them to breathe anyway. Put them over onto pressure support so that their spontaneous breathing gets a bit of pressure. Let them wake up on that. That's nice for them. It's not causing too much effort. You also get to practice the mode. And you can extubate off pressure support, or if you're nervous, get them wide awake and go over to spontaneous ventilation to see how much support they need. And you can see just by that circle above the pressure support, there's something called the trigger equals 3. That's telling you that it wants to hear a flow rate of negative 3 liters before it gives that pressure, which may be a bit high. So you may want to fiddle with the trigger. So as a general principle, start with one mode of ventilation, either pressure or volume, and get to know that well, and then learn to use the other one because they're both useful in different circumstances. Practice with a test lung, and this is something that's easy to do, and watch the traces. Watch them, learn what they mean, and adjust your ventilation as you're going, and very quickly you'll become an expert at the basic modes of ventilation. Thanks very much.